Good evening, everyone, and welcome back. Can you guys see my screen, the slide deck? Thank you. Thank you so much for joining us again, which is today actually our sixth and last session on gender dysphoria. I can't believe we are at our last session. We really appreciate your attendance and your input and your support for Community of Practice. So we'll start out today's session by acknowledgement of country. We would like to acknowledge the peoples of the Kulin Nation as the traditional custodians of the land on which we are meeting today. We recognize their continuing connection to the land, waters, and culture, and would like to pay our respects to elders past, present, and emerging. Our guidelines again, so stay on mute, please, unless speaking. Raise your hand to speak, keep conversations confidential, introduce yourself and your role while you're speaking. Share ideas and promote everyone's participation. Acknowledge that we have varied needs and interests, and please feel free to ask any questions. A little bit about myself. I'm Saha, one of the GPs working at Gunawara Medical Center, working in the community for about now 8 to 9 years. Our guest speaker for today is Dr. Tram Nguyen. She's the lead psychiatrist with Royal Children's Hospital Gender Services. She's passionate about equity in the healthcare provision and is a strong advocate for marginalized people. In her other roles, she's the clinical lead of the Specialist Mental Health Service, the Cabrini Asylum Seeker and Refugee Health Hub. She's also a long-standing consultant with Women's Alcohol and Drug Service, the Royal Women's Hospital. We have Dr. Prakesh here. He's a senior consultant child and adolescent psychiatrist at RCH with over 20 years experience. He has worked in and managed general and specialist clinics within child psychiatry in metropolitan and regional public mental health services. Prakesh has worked with children and adolescents from 4 to 18 years of age, assessing and managing a variety of mental health issues. So today's agenda, Dr. Tram would present the education component on gender dysphoria after some slides on health pathways. And then we're not going to actually go through to the breakout rooms, considering it's last session, and we'll have just mutual discussion in the bigger group. So I'm just going to hand it over to Dr. Tram, please.
Thanks, Saha. And can do I have control of the slides?
Yeah, sure. Do you want me? Yes, you can share your screen.
Oh, no, but I've got your slides, but do you have to flip through them for me?
Unless you share the screen yourself, yes, then I'll have to do it for you.
Okay, because I haven't opened up a copy of my slides. Okay. So we've got to
take time to do that first. We can wait if you want to.
Let's see how long it will take me to get it up, because I'm actually not where I usually am, because there was an event this evening, which is which was the filming of The Dream Life of Georgie Stone, who was the third young person at the gender service who has had gender affirming care with us, and she's got a documentary out called The Dream Life of Georgie Stone, and it's now available on Netflix, but it was filmed, it was shown today at the Children's Hospital. Otherwise, it would usually be I'll probably be home or in a different office. Okay, so I've got the slides up now. So if I share screen, then I will.
Sure, I'll stop the share and you can.
Okay. Is that sharing now? But not the, wait a second, there we go. Okay. My only problem is now I lose you, but I will see if I can still, just trying to organise so I can still see the participants as well. Okay. Okay, so I've been at the gender service for the last 5 years, and I would like to acknowledge that I've had there's a whole team, and some of these slides are from a group of us that we share as we do a lot of speaking. And this is us at the Pride March. This is one from a few years ago. And so the background to this is that...
sorry to interrupt you. We can't really see your slides, moving, just the slide deck, like the slide that you are going.
Oh, it's moving for me. That doesn't move for you?
Not for me, I guess. You're on mute, Tran. Sorry. Do you want me to share?
Yeah, why don't you share, and I'll just unshare. Have I unshared yet?
Yes, you have.
Yeah.
Let me know if you can see that.
Yeah. Okay, go to the next slide. And the one after. Yeah. So there's been a great deal more visibility for trans people in the media, and so we are getting a lot more referrals. And obviously you're all here because you're interested in learning more about it. I think we had in 2020, we might have had around 400 and something referrals for that year. Last year we had over 800, and we're probably heading towards 1,000 referrals this year. And historically, why it's been the care has been largely in the hospital is because that there was a requirement to go to family court for young people to seek gender affirming care, and that's changed. It's not perfect, but it's changed. But that means that it has taken away this legal barrier, which is discriminatory, to allow young people to access care in the community with GPs, with paediatricians in the community, and mental health clinicians as well. Okay, next slide. So gender identity evolves from a young age, and it's a really deeply felt sense of self, which can be either male, female, neither, something in between, both sometimes. And for some young people, and I've had a young person who is autistic and developmentally delayed, still at 16, incontinent, wearing nappies, but his first words, and he's a birth assigned female, his first words, as his mother says, is "me boy." So even at that age, you could communicate. And if you think back about when you had your sense of your felt gender, how old were you when you knew, or you had a sense of whether or not you're a boy or girl? And this should not be conflated with sexual identity. So sexual attraction identity develops typically later, when people start going to puberty and thinking about the relationships and the attractions that they might have. Next slide. And some more around terminology. So gender expansive is a term we just use for people who might identify or might express themselves in a way that doesn't conform to what stereotypical culture would expect them. So it might be a boy, assigned boy, who is more feminine, long hair, wears nail polish, what have you. That doesn't mean that necessarily he's transgender, but it might that the way he expresses himself is not what people would expect. And we've seen this change throughout the history of time. So 100 years ago, it was women did not routinely wear pants in Western society, and now they do. And so when people push against these gender norms, they can expand what is socially acceptable. And an older term for that is gender variant or gender non-conforming. And so the word transgender is basically someone whose felt gender identity is not congruent with their birth, the sex assigned at birth. And your sex assigned at birth is largely based on your genitals, and it may not be your chromosomal sex either. because who gets their chromosomes to detect out? Well, not of our generation. You know, babies now have antenatal tests and screening where you might know that. Gender dysphoria is that sense of distress when trans people do feel that there's this mismatch between their felt self internally and their anatomy and their sex assigned at birth, and that then leads on to how people gender them and how people treat them as they're growing up. And a cisgendered person is someone whose identity and sex sign of birth are aligned. And that comes from, you know, it actually comes from organic chemistry with cis and trans bonds, if you can go back to that time. Non-binary is a relatively new term. It's for people who identify beyond the binary of male or female. So you could be anywhere along that spectrum or something other. And gender fluid is for someone whose gender varies over time. Next slide. And this is just one of the educational resources that we might use to educate families, and I get parents to think about that as well, and to really separate it. What's your sex assigned at birth? What's your gender identity versus your gender expression? And your expression is the outward part of it. And quite often young people get bullied on their expression more than their identity, because unless you ask someone, you don't actually know how they identify. But what we see is, you know, feminine boys get bullied, and that's on an expression of gender which may not align with how their identity is. And then the bottom two sections around physical attraction and emotional attraction, and there we're seeing great more variance around that now. People are not just identifying as heterosexual, bisexual, young people call themselves pansexual or asexual, or they might be you know, asexual panromantic, so separating out what is sexual attraction versus emotional connection. Next slide. I did put in, that's our referrals for the year, and we'll keep going from there. It is heartbreaking to watch sometimes. If I were to give this talk about 5 years ago, the stats I would have given would have been about 1.5 to 2% of Australian young people to identify as trans or gender diverse. But studies, surveys now have shown that that's increased. Yep. And the next one is around the trans pathways. And the next slide there, Saha. And this is a major study out of WA, and it's an interview of 14 to 20-year-olds and 21-year-olds and their parents about their mental health experiences. On the next slide, and we've got, this is what we are concerned about, that, you know, disproportionately high levels of co-occurring depression, anxiety, eating disorders. The eating disorders is sometimes about controlling body of, for instance, a trans male who doesn't want the curves of the feminization, and so control it with eating. And the next slide, sorry, the next, yep. And really, really high rates of self-harm and suicidality. And what we see this attributable to is not the fact that people are trans. It is the fact that the larger proportion of it, and if you go to the next slide, Saha, is around, oops, I didn't put it in. It's actually around the discrimination, the bullying. So what I hear from young people is actually staggering. That some are still getting, you know, sexually inappropriate bullying at school, being called names that I could never think of, and that's what. And so when you're bullied, anyone is bullied and discriminated against. What the message that these young people are getting is, you are wrong. You are wrong as a person, and how that affects your sense of self. That sense of you're rejected as who you are, and being yourself is not right. And so people do internalize and think, and there's this poor sense of self-worth, and that can lead to self-harm and suicidality. Some of it relates to self-harming the parts that they want to reject. Self-harming of breasts are quite common, and then also anxiety. So anxiety around, how will someone perceive me each time I go out? Will they gender me correctly or not? So how can we help? Next slide. It's really supporting young people in affirming their gender. And this is a really broad term. This does not mean we're going down a medical pathway. Next slide. How do we start? Next slide is to listen and empathise. And this might sound easy and straightforward, but actually it is really not. And quite often parents really struggle with this. Next slide. This is a recent quote from Brené Brown, who's a professor in the US around, lost my words today. This is the fifth hour of presenting I've done today. She's a social scientist and she's got written lots of books, but a recent quote she had was around empathy is the choice to believe, and it's intentional, to believe people in what they're saying about themselves that does not resonate with our own lived experience or what we need from them. So when a young person tells, when a young person tells a parent that they're trans, empathy is not, are you sure? Empathy is not, how can you know, or maybe you're gay, or that questions that won't take the young person as they are. And what I really try and message to all people, when a person discloses something like their gender identity or their sexual identity, something that's really deeply personal, that's like, I can't take this, I can't just take this off. This is who I am, and I'm telling you this, and I'm at a point of vulnerability. What I try and get people to, the response is, thank you for telling me. What do you need from me now? Or I still love you. It doesn't change us, and that's what kids need to hear. Okay, next slide. And if you keep going, it's a series. So what we do at the gender service, we listen and listen. More listening. We empathise. We be self-aware of our own judgments and not be judgmental. We put the young person at the centre of decision making, and we respond to their needs. And this may come in the form of their preferred name and pronouns, their social presentation, how they want to look on the outside, the identity documents, Medicare, passports. And at the very end, we might consider puberty suppression or gender affirming hormones and menstrual suppression as well. The next slide, and what do we listen for? So what do we do when we take a gender history? Next slide is a history of a young person's experience of their gender and expression. So I have a young trans girl who is 8, and she said to me, this is a year after I'd seen her, and she said to me, I knew when I was a girl. I was 4, and Grandma had sent a dress in the post for Grandma lives in Warrnambool, sent a dress in the post for their younger sister, and it didn't fit them. And they were signed male at birth. They put on the dress and they said, oh, it just felt like right. It felt me, and I wanted to just keep wearing it. And she could pinpoint it to that very moment. We ask about distress and dysphoria, and particularly young people who talk about wanting to, cut off their penis or those kinds of things. Distress around anticipated body changes with puberty and their experience of it, and where they have taken steps to affirm. So yeah, some young people might be using avatars online and what have you that are their identified gender before they even speak to anyone in real life. And it may be that if they feel safe at home, that might be the only place where they start to play with gender, with what they wear. They might only wear, dresses at home, but not do it at school. But what I tell parents is, if you don't allow for it at home, what happens then is they will take it somewhere else and do it, and you won't even know. So that I know see some young people who've been really rejected by their family, and they have a set of clothes that they wear at school, and they change back when they go home, which is a sad situation for the entire family. So we ask around the acceptance or lack thereof amongst families, friends, school community. And for some parents, it's they're actually worried about the rejection that they will face from their own parents. It's like they have a sense of sort of shame as well, that somehow they're parented wrong, and that's how they end up with a trans child, that they've been too permissive, and their own parents might judge them on that. And so sometimes I've had grandparents in to have discussions and do some education. Always ask about discrimination, bullying, rejection, and also their own self-understanding. So sometimes with autistic young people, they might conflate expression with identity. They sort of say, I wear a dress, therefore I'm a girl, or and as they develop words and understanding, sort of trying to get a sense of what is dress up, but what is how you feel on the inside. So if you have someone who's neurodivergent and has developed mental issues, it's going to take a bit more time to understand what their experience is. Next slide. And again, we can go to the next one. This is one we use similarly. This is what young people might get online as their questionnaire about how male they feel, how female they feel, or how non-binary or gender neutral. And it says there, and it gives them the option of, I'm not sure, I don't understand the question, I prefer not to answer. And when they do it online, there's a toggle that they can do. When I do with kids in the room, I just draw a line and I put numbers 0 to 10 or 0 to 100, depending on what I think that their developmental age is and that they'll engage with. And some young people will come in and they'll sit down and start drawing themselves each time I see them, so they can tell me where they've changed or not. Or I have young people, and usually it's quite often the neurodivergent ones, who say, I told you last time, it hasn't changed. It is still 99 there and 3 here, and stop asking me stupid questions because I'm neurotypical and I ask stupid questions. Okay, next slide. So this is the DSM-5 diagnosis for gender dysphoria for children. And what you'll notice is it's outdated, and it's partly outdated because it talks to a lot of the expression. It talks to what you do, what you wear, what your interests are, who you play with, and rather than the internal sense of gender identity. So that's where I think it doesn't fit. And particularly when you've got non-binary young people, you have autistic people who don't conform to gender expression anyway. I have, you know, the autistic young people only wear tracky dacks and sketches because that is the most comfortable thing, and they cut off all the tags. But that's sort of saying that, you know, how is it that we as observers get the clue rather than, you know, should we be asking? Next slide. And this is the criteria for adults and adolescents, which has a little bit more around identity as opposed to just expression. And some would argue it's not the strong desire to be the other gender. Some would say I'm already that gender. It's just that my body just doesn't fit in that way or not perceived in that way by others. I have a young person who's autistic and male and 14 and 15, considering whether or not to go on hormones. And he sort of said to me, he's sort of crying, he says, when I'm here and I'm by myself and there's no one there, I sort of think if I leave it, I'll just automatically, it will happen. I am a boy, that's how I feel. So of course I'm going to have a boy puberty. And then I go out there and I get gendered as female, and then I realize, okay, I actually need the hormones because it's not going to happen. And it's that interface with the social perception that actually gets him quite teary and depressed. Next slide. So what else do we listen for? We go to the next slide, and it's around what I spoke to last time. Go to the next couple of slides. It's around the co-occurrences. So we think about gender, we think about what are the co-occurrences in terms of mental health presentations that we need to look for, and to do safety planning if we need, refer for, you know, eating disorders, or for other things like neurodiversity. Do we need another assessment? Next slide. And thinking about what is contributing to the presentation, the external factors there. And in the next slide, yep. And so when people intentionally call the young person by their non-preferred name or their birth name or their non-preferred gender markers, pronouns. So I've had some young people who've been called it at school as a form of bullying. and being outed. So there are some young people who don't want to be known as trans, and lots of people say, I don't want to be trans, I just want to be cis. I wish I was born cis. I wouldn't have to go through all these appointments. I wouldn't have to need medical treatment. I wouldn't feel like I'm wrong all the time. And so they might, for instance, enter a high school and not tell anyone and move to a different area. But then someone comes along from, from football, what have you, and tells the entire class without their consent. And there they feel quite vulnerable. And this is some of the issues around how that leads to self-harm and mood and anxiety. And so I do also spend a bit of time speaking to principals, vice principals around safety plans and affirmation plans for young people. The next slide. And we've done our own studies with similar rates. You can keep going. So I've got a couple of slides because this gets commonly asked, is around neurodiversity and gender diversity. And some of the rates around the world is around something like 16 to 20% of gender diverse young people, also neurodiverse. And similarly, there's a higher rates of gender diversity amongst those who are neurodiverse. And we don't really know whether there's a biological, and it's going to be multifactorial, as with most syndromes or presentations. And previously, it has led to obstruction of healthcare for those who are autistic and seeking medical transition, because people were saying things like, is it just an autistic fixation, an obsession? It's not really real, and led to people not being believed because they don't live a performance of gender in a binary way that others might code as understandable for them. And one young person actually told me, because their mum said, how do you know it's not an obsession? And they're like, Mum, K-pop is an obsession for me. I actually really enjoy it. I really hate being trans. I just have to do this. That's one example. And so sometimes when, for instance, a young person gets fixated on Frozen and only wears Elsa dresses the entire time, that's about expression. It's really hard then to know without the language how much of this is going to be identity, not just expression. And so that's why it takes extra time to get an understanding of where that young person is at. We'll keep going. The next slide. And so gender diversity is an expected outcome in individuals who are less contingent on social information for identity development. The next slide is a quote from Lydia Brown, who's an advocate, who says that being autistic doesn't cause my gender identity, but it is inextricably related to how I understand and experience gender. And so for people who are autistic and gender diverse, what we find is that maybe they don't communicate the dysphoria as intensely as we, and then so we might not take it as strongly, or they might find challenges in verbalizing what are their goals around affirmation and advocating for themselves. I've had young autistic people being too scared to ask for their parent to use the pronouns, and it's the parents who've had to actually say. Or they might, and neurodiverse young people also have that layer, that intersectionality. They've already bullied and discriminated against for being different anyway, and particularly if they also have ADHD and tics and what have you. And also the sensory experience. So we talk through with the older trans and autistic young people around, now what will it feel like when you develop breasts? Will that really bother you? Are you up for some of that discomfort around your body? The next slide is a little thing on masking. And I put this there because for lots of autistic people, especially if they're assigned female at birth, they're used to masking. They're used to putting a mask so that other people won't see them as different. And because of this, and because they might not communicate their sense of identity to parents earlier, and then they just talk about it, it seems to parents that it's all of a sudden. Whereas with the young person, I've been thinking about this for years, and I haven't said it because I've waited to when I'm sure of it. And in the meantime, I've been masking. They don't say it in so many words, but that's the experience that we see. And so what we know that gender diversity is not a mental health condition. It's around dysphoria, it's around discrimination and the minority stress that they feel. But what we do know is those staggering rates of mental health presentations reduce when they are supported to levels similar to their cisgendered peers. And the single most important factor is robust family support. So that's why parenting work is always a part of this work with young people. Next slide. And gender affirming care gets used in ways that are misleading, and particularly in mainstream media. And all that means for us is that you meet a person where it's at when they talk about their gender identity. You don't question them, their belief. You don't come to a point of assumptions and judgments. And that doesn't mean that all youths will go under medical transition. And I think our stats are maybe half of our service at any one time, not the majority. And that the care is really individualised around, sometimes it's actually getting parents to understand that this young person has just told me they're worried about their bathers, and they really appreciate just going shopping for their bathers, different set of bathers that will align with their gender, and that reduces dysphoria. Or they want a haircut or a binder. Next slide. And this is what our mental health clinicians would do. They would do a developmental mental health assessment, really looking for neurodivergence as well as any other developmental delay. We do a lot of education of the young person and the family, and it's quite often catching up the parents to the young person and working on issues around grief for parents, addressing the co-occurrences, as I mentioned, in the usual interventions, and looking at a individualised plan. So we do lots of family work, we do advocacy and assessment of capacity if needed. Next slide. So in 2017, we published the Australian Standards for Care, and we're just in the process of updating them, and we're probably looking at next year to update them. The other place to go to is WPATH, which is the World Professional Association for Transgender Health. They just released their latest standards of care in the last month, so they're just hot off the press. And they've got guidance around management of adolescents and children with gender dysphoria. Next slide. And really, this was groundbreaking work. And if you go to the next slide, it was quoted in the Lancet and talking about how children and adolescents with gender dysphoria often experience stigma, bullying and abuse, resulting in high rates of mental illness, including depression, anxiety and self-harm, but with supportive gender affirming management as laid out in the Australian guidelines. So we're already expecting this editorial from the Lancet. These consequences can be minimised. And go to the next slide. So as I mentioned, gender affirmation can come through that lived experience, which we don't have to worry about. I wake up, I don't have to worry about my gender. I don't have to worry about someone's going to mistake me for anyone else in terms of my gender and what I wear and what have you. But for young people who are gender diverse, this is going to be really important. And just a young person being asked if, you know, they wanted their mum to buy them a scrunchie and they were too scared to ask. To the legal affirmation around identity documents, including birth certificates in Victoria, where we can change the gender marker. And then very lastly, the medical affirmation. If you go to the next slide. And so what we have at our clinic, this is our model of care. We have a triage first session clinic for those who are 8 and over. And this really looks at staging the young person in terms of their puberty status. Go to the next slide. And then, and also thinking about what their preferred pathways are. There are some who don't meet us and they exit the service at that point in time. And then there are those who we move on to the multidisciplinary team, where every young person has a mental health clinician and a paediatrician who is assigned to them for the entire duration of their care. And we see them up until they finish school. And we fast track them if they're peripubertal and they need puberty blockers, because waiting around is not a neutral option, because puberty is permanent. So once someone is, you know, for instance, they're post-pubertal and they're a trans boy and they've got breasts, then later down the track they might be looking at surgery. And if we had caught them at puberty blocker time, then they would, and we usually have it at around stage 2 or 3, Tanner stage, then that need for future surgery would have been taken away. And also, next slide is just there for completeness. We don't do surgery at the children's, but that's just options for what people might have down the track. And surgery isn't offered for under 18s in Victoria. The next slides are, we skip the next couple. We'll go to the next one. So this is really, sorry, the next one. What we do here. So we just might have a paediatrician, and I'll put in their GPs for what you might do. And but all along the way, we've got a mental health clinician there as well. And so this multidisciplinary dual care model. But we also refer to other places, people. So if someone is wanting mental suppression but might need a Mirena, we might refer to our gynecologist. People who might have speech therapy for voice modulation if they're post-pubertal and they can't change their voice through medical transitioning. And we might refer to support groups, peer support, and family therapists if there are issues within the family. Go to the next slide. I wonder how many, I'm just going to flip through these. So if you go to our website and you look at the standards of care, that blue document, you put in RCH Gender Service, standards of care, it will come up. And I've just put these slides here, but really there's guidance around studying hormones including what to discuss with young people in the standards of care. So that's estrogen. We start at lower doses, and this is testosterone, and we're moving more to some young people preferring the Testogel. So a couple of slides just on, these are the studies on persistence of trans identities in young people. And what we're finding is that when you come to the gender service, it's actually, some of these young people would not have had medical treatment. Actually, they probably wouldn't have for a lot of them yet. But what young people tend to persist in their gender identity once they've reached our service. And bear in mind that we've got a wait list now over a couple of years. But parents quite often worry about this. Sometimes they go, you know, can they socially transition before they see you? And well, social transitioning is always reversible. And so it's about, well, why don't you let that young person try it on? That's the best way for them to actually know whether or not this works for them. Next slide. And the biggest study, the AMSWORD cohort study of over 6,700 people, was around the rates of regret, and particularly those who have experienced, who have had medical intervention. And it's really, really low, less than 1%. And most of it is due to social issues around they couldn't bear the social rejection they got from their parents or loss of employment, rather than the actual treatment. And that's a phone line. It is man 95 by our resident. Feel free to call it, and the resident will then triage whether or not they can answer the question, or whether or not you'll get one of our peds to call you back, or I will call you back, depending on what you might require. Okay.
Thank you so much. That was really, really informative. So, just a couple of slides before on health pathways, my favorite topic, before we head on to our discussion. So health pathways basically provides clinicians with a single website to access clinical and referral pathways and resources at the point of care. Basically, it is written by GP clinical editors with support from local GPs, hospital-based specialists, and other subject matter experts. It is evidence-based medical advice. Benefits are that it definitely reduces variation in care, also gives us an idea on how to refer to the most appropriate hospital, community health service, or allied health provider, and what services are available to my patients. So these are the guide pathways that you can access through the health pathways. Some of the examples on the topics that we have discussed in community of practice, and there is an option of giving feedback if you think something needs improvement. Now, how to register for those who are not familiar with health pathways. So you just go to Health Pathways Melbourne website and you can register now. And they send you a password that you can use to access the health pathways. So we'll discuss our case scenario next, and then we wouldn't be having any breakout rooms today, and we'll just discuss the case in the group as such. So scenario part 1, 11-year-old Sam comes to see you with his mother. Sam is a birth assigned male who is in year 5 at school, but has been reluctant to go to school over the last 2 terms. He says he's not sure he wants to be a boy, feels different to the other kids, and has been on social media and YouTube and thinks he might want to be a girl. He says he feels more comfortable in girls' clothes. How would you approach the session? And what other information might you want to know? So I'll just stop sharing and then we can have a discussion. Please feel free to unmute yourself so we can just discuss together. Nobody? I would say, like, as Tram mentioned earlier, the most important thing, I think, is listening, and lots of listening and empathizing, and just asking them to perhaps, elaborate on his experience. What would you say? I'm going to just ask randomly if anybody wants to come in. Linda, do you want to add anything? Sorry, I just saw you first. If you could please unmute yourself.
I think just by really open-ended questions about, not even asking about gender, just, what can I help you with? What's really troubling you? Just to see where they're at. And, it's probably a really big step to make that first appointment and to come. And so, yeah, I think setting the tone of, this is a safe space, and it's, really important. Just be really open, and rapport is vital as the first step. So, and then see where you go, I guess.
Absolutely. And what other information generally, would you ask in a situation like this? Like, anybody?
So maybe like how we sit like at home. So it seems to be like this child has come out to his their parents. So how is the situation at home? Like have they come out? What's the about like any preferred pronoun, whether they are like the family supportive, yeah, and what about the extended family, whether there's any stress around that, like in the family situation, and like the heads assessment we do, like, yeah, the part of it we can do for the child, yeah, and in the school, how it's at the school,
Yeah, great.
yeah. And the least the story, like how long he has been like a feeling like that. Yeah, the particular their experience. from like early childhood.
I think Joanne is making a really good point about, like, exploring perhaps how was mom's reaction. I think mom, to me, I'm just making an assumption, perhaps mom is really supportive and that's the reason the child is here. And what would he like to wear at school, as he has been missing school? Would he like his parents to talk to his teachers about it? And again, what does he need to move forward? Really good points. Tram, do you have any recommendations of how we can approach if a young person presents to us like this?
And I think it's really individual, because sometimes, how was the young person, 11? Sometimes the young person doesn't want to speak at all, and it's a parent speaking. And you sort of respectfully say, is it okay, mum can tell some of the story if it's a bit hard for you, but also reassure them this is just the beginning of a conversation and you'll come back to it with another consultation. You really want to know what's made Sam stop going to school. Has there actually been some bullying? Has there been issues there? Are there any other learning difficulties? At the gender service here, we always spend some time alone with parents to get a developmental history as well. And yes, it's doing that head screen, but doing it with a bit more detail. And has there been any other times where they've not attended school, or any other mental health concerns, so the co-occurrences as well? And really a sense of, their social functioning. So the whole young person, what else are they participating in? How's their growth? How's their eating? Are there restrictions? All those things, but you won't get it all in the first session. So it's really thinking about booking in for a long session next time, because they might have only booked in for 15 minutes, and then thinking about what they might need now, and what has the mother come in as well, because they brought the young person in. Because sometimes it's like, can you just write a referral? We have parents to do that as well.
Thanks, John. I'm just gonna head to the second part. Anybody wants to add anything? I guess no. Let's have a look at the second part, and then we'll discuss. So the second part of the scenario is that you speak with the school about how things are going for Sam with respect to his school engagement, learning, and friendships. They confirm he has been absent for many days this term, is doing okay academically despite this. However, he has been subjected to some bullying, particularly by other boys. Sam and his mother come back to see you 2 weeks later, and Sam says he wants to transition now. You know the wait list for RCH gender service is very long, and the family cannot afford to go privately. What actions, support could you provide Sam for him to feel safe at school? And what can you do now while Sam is on RCH gender service waitlist? That's actually a really good question that I am, as a GP myself, interested in as well. Because, as far as physical assessment of things is concerned, establishing what tenor stage they are on, and what do we do generally? Like, if they would benefit from, puberty blockers, and we can't really access the services, how do we go about it?
I didn't write this scenario, so this is a slight trick question. In the sense that actually they do need to be referred to us, unless the family can afford $1,500 per puberty blocker shot 4 times a year. So we actually will take all of those young people on and try and fast track them so that we don't miss that puberty for them. And so when you look at our referral form, there's actually I think there's a bit that says, have they gone through puberty, or where you think that they are in tenor stage. It doesn't necessarily require that you do a physical examination of the young person. Sometimes if they're unsure, we'll show them the diagrams and they'll point to which bit that they relate to in themselves, and they can give an idea of that. And we're looking at standard stage 2 or early stage 3, where we usually start. And all the other option is doing some bloods, so doing LH, FSH, and estrogen and testosterone. We do that at baseline to get a sense of whether or not someone's reached, biochemical puberty as well.
So what is the general, the number that you mentioned? If we have a patient who would benefit from puberty blockers, so there is an option of ringing up and trying to expedite the referral?
No, just put it through. We will read that. That's
Yep.
one of the things that we read, and we'll look at that. Whereas if someone is post-pubertal, if they're sort of stage 4, late stage 3, so 4, if they've reached menarche, if their voice has dropped, then the puberty blockers aren't likely to be able to do much at that stage. So we would have missed that window. That doesn't mean it's the end of the world. So I let young people, up until recently, trans people did not have medical transitioning until they were adults, and now there's a documentary of a person who transitioned while they're in a nursing home. They finally got to be their firm self. So it's never too late. It's not the end of the world. But for a young person, when they're driven by urgency, sometimes it's hard to hear, and just thinking about what are the other options, how else can you affirm, and linking them in with groups. Like there's a group called -18. For parents, there's a group called Transcend. There's also a Facebook group called Parents of Gender Diverse Children. It's a closed group, so I can't put myself on. I don't know what gets said about us on that group. So parents can access other supports as well, and thinking about where they share information and experiences.
And young people who have actually reached puberty, can we initiate some form of hormonal treatment while we are waiting for them to get specialized service?
And that's where we would encourage it. So a trans male where there is dysphoria around menses that you could start. You could start mental suppression. You can go on our website. We've got some guidance around that. Or you call the phone line. It's use Primolute, because trans boys don't like having exogenous estrogen in them quite often. We've also guidance around testosterone and estrogen prescribing. But you want to have a mental health clinician involved to do a general overall sense of their mental health functioning, and whether this is the right decision for them. We don't do this in one session. We do it over months when we're considering medical treatment for young people.
Thank you. Bronwyn, you can please unmute yourself.
Thanks so much for tonight's presentation. Can you hear me?
Yeah.
So good. Okay, I've had a bit of trouble recently on meetings. I just wanted to ask a question, if it's all right. So one of the things I'm finding increasingly is kids coming in at maybe 9, 10, 11 years old and identifying transgender or binary or, lots of different ways. But often that's the start of the conversation between them and their parents, and them and their friends and their broader community. And I'm in the inner west, and so generally there's a lot of support at school, which is really great. And my kids are in primary and high school, and they're all over supporting their friends who are gender diverse, and so all that's fine. But often it's kind of the beginning of the conversations with the parents. What worries me, or what I just think about a lot, is this thought of this kid's about to go through puberty. How urgent is it that we're having the discussion about whether they want to have puberty blockers, when maybe the child themselves and the parent are not quite there yet? So I have this kind of conflict a lot, thinking, this kid, is this kid going to need puberty blockers? And in 2 years' time, are they going to go, well, why didn't that GP get me on puberty blockers? But when I'm speaking to them and their both them and their families, I haven't had a kid come in yet going, yes, I want puberty blockers. They're like, oh, this is where I'm at. So I guess I'd really like some guidance on how to.
Yeah, and so you might suggest a referral to us in the same way that you might suggest a referral
Yeah, no, that's
We'll go to another specialist for another thing.
Well, I do that, but if they're not quite there and they're thinking I'm not going to feel confident to raise it as an urgent issue because they're not coming in and saying this is an urgent issue.
You don't necessarily need to raise it with them. We can raise it.
But will you fast track it with your 2-year waiting list?
No.
You know what I'm saying?
You're asking a stage of puberty. So actually, we generally fast track those who are 11 and under.
Oh, okay. That's super helpful information. Yeah, okay. Yeah. So we'll just, okay. Because I'm also worried that you guys seem, like quite overwhelmed with all your referrals. And so then I'm like, well, I don't want to be overwhelming a service if this kid doesn't actually need to go to your service, and I'm finding it hard to judge. I tend to just refer them all, but that's probably not helpful for you necessarily. Yeah.
No, it's completely fine, because then we actually have people then when they get to us, they go, actually, we don't need you, or we might have a drop off of about 25%.
Right.
Okay. And we rather have that than someone just a lot later down the track. And we and I've had young people who come to me and they're so stressed they can't even speak about it, so they can't even formulate the puberty blockers thing. And I bring up the discussion and just put it out there, and they go, no, it's okay. And then I get a distraught email from parents saying, oh my God, they're worried now. They're worried their voice is scratchy, and then I go, okay, we'll rebook you back in quickly.
Yeah.
Because there is that ambivalence as well.
Yeah. Often, people are not really sure, and so it feels like it's difficult to help them to think either way, really.
And so puberty blockers for me is not, gender. It's not a gender affirming hormone. The puberty blockers just put a pause, and it's reversible, so that often we have people who aren't sure, and they go on and then we explore gender more from emotional, psychological perspective, and allows time for more social transitioning as well. And we've had people go on blockers and then come off them and decide, actually, now that I've done all this, I've realised, and they haven't. But when they're so distressed by puberty, they can't think. Like, the noise is too loud for them in their head to be able to think. I think that's the luxury of puberty blockers. We've seen some people, non-binary people, young people have to decide whether they're going to go with an exogenous or an endogenous puberty in the end, and they have to make that decision.
Great.
For that time, have young people who go on blockers, off blockers, and go back on, and then sort of deciding. So there's no one pathway. It doesn't set you up for having gender affirming hormones on the track, right, from our perspective.
Okay. Thank you. That's really helpful. If they go on blockers and then come off them, does it affect? Will they just catch up with where they were going to be in puberty anyway, or will they kind of start from where they were and then they'll end up do you know what I mean? Does puberty take the same amount of time and it shifts it this way? And do they end up at their final height? I think they're the two things that I worry about most.
Depends on what you're asking about. So it's really interesting. So from an emotional perspective, I see these kids on blockers, but they're behaving emotionally like teenagers in the affect dysregulation. So it doesn't affect everything. I see them develop cognitively, so it doesn't stop that growth. So what happens is that when you're on puberty blockers, your end plates, the pivotal end plates are infused. And so it depends on where you've been altered in your puberty, whether or not you'll end up a couple of centimetres shorter or taller, where you've got that growth spurt or not, or you keep growing and then you reach another growth spurt with your sex hormones. And the main reason that people can't go on blockers forever is around bone mineralisation. And so we do a DEXA at the time of starting blockers and annually after that. And if it looks like their bone density is dropping because they don't have sex hormones, then too much, then we consider getting them to decide on which puberty sooner rather than later.
Okay, thank you. That's really helpful. Thank you.
Thanks. Those were really helpful questions. And thanks, Tram. Joanne has made this point about the social side of things, like how to help, that engage teachers in pastoral care, read the bullying situation, consider with extensive discussion with Sam if he may like to may like to try socially experimenting out of school first, which may be less confronting initially. So if we
go on.
No, I was just about this socially experimenting out of school first. So if a child has presented to me and have mentioned, so is this sound advice to give whether they would like to, you know, I don't know, express themselves as the desired gender for a little while to see how they feel about it? Like, I don't know if I'm wording it appropriately.
Yeah. And it's not all or nothing. It's what they might feel comfortable with. So I have young people, trans boys, who start with long hair and they get to shoulder length, and then they get to a bob, and then it gets shorter, and that's how they progressively feel comfortable. Or maybe only one space that feels safe for them. So they may only be a group of friends, close friends, who call them their chosen name and pronouns. And then if they feel that's accepted and that's okay, they decide what is an acceptable, what is a comfortable step for them. And then they decide, does that make me feel better or worse in a way? And it's really what the young person feels. I saw a young person who was 17, reached puberty really late and was on puberty blockers, but could not manage social transitioning. And the reason why she couldn't was she was bullied so much because she's autistic, would have balls thrown at her and what have you. And she sort of said, I don't feel safe to do this until I have estrogen and I feel like I'm worthy and I'm okay. And I want to do this over school holidays so that other people, at the end of their year 12, and hope, almost wanting to become like a butterfly at the end when they start their next year. So thinking about, people's judgments in terms of how safe they feel.
Thanks. I have had I haven't really had many pre-pubertal kids who I have seen in my practice, but I have had quite a lot of young people post-puberty, and I ended up referring them, and they are on a testosterone treatment. Just that makes me reflect, like, was there something, like, was I able to initiate some form of testosterone treatment for them apart?
Yeah, so the reason why, up until basically 2017, why the treatment has been through us is because of the legalities that I had to go through family court. So it was a big administrative burden to have private practitioners do that, and we've got a legal service who backs us and what have you. And the ruling, and then they got updated, the ruling in 2020 is that you need both parents on the birth certificate express consent from a legal perspective to then initiate testosterone or estrogen. And if you don't, then legally you can't and has to go through court. So if you do, and if you're considering it, ring the phone line. We can hold your hand and step you through it.
Thanks.
But we do need both parents to consent unless there is one parent who has legally sole parental responsibility.
Thanks. Does anybody have any questions for Tran?
Yeah, and so we would talk you through what kind of bloods you want to do first, how often you want to do monitoring, what doses, what are the formulation options.
Do we have to get a WPATH assessment for those kids who want to start on the gender affirmation hormone therapy before they are 18?
So we don't call it a WPATH assessment. We call it, because we provide sort of a comprehensive wraparound service. But I would say that it'd be ideal for them to see a psychologist or a counsellor as well around that. So there's someone else working with the young person with you, if you're a GP. And the question around how to support parents coming to terms with their child's gender dysphoria. And this really varies. And looking at it culturally, yes, I have a couple of Vietnamese families. One family is really supportive. The other family will say you can't do anything until you're 18. And so I always try and spend a lot of time with parents on their own. I will tell the young person I will do that as well. And talking through issues that parents have imagine I did a parent group last week, and the parent said, I'm really open, but when it came to my child, I was so freaked out. I was so worried. The things going through my head is, will they harm themselves? Will someone else harm them? This is a really tough place for them. I just, I want my child to go back being cis, because the world is a horrible place for trans young people. And it's that they're grappling with, or they're thinking, what if I sign the consent and I make the wrong decision for the young person, and they're going to blame me when they regret it. So there's a lot of that. And so sometimes it's actually good for the parents to see a psychologist as well. And the other support I would really recommend is Transcend. And Transcend was developed by a parent of Georgie Stone, and Rebecca Robertson developed that organisation, and they've got support workers for parents there as well.
Thanks. Anybody has any questions? I might ask Dr. Prakash. He's quiet today, so would you want to share anything?
I don't have any questions, and we've got the expert today, so I'm taking a step back and I'm listening and taking it all in.
Great. Oh, yes, Vesna, please.
I've got a question, and I'm just wondering, so sometimes there's young people who have a really fractured relationship with their parents, and trying to obtain consent really isn't a possibility. Does that mature minor sort of principle come into play in instances like that?
Well, this is a fraught issue, and it's a fraught legal issue, because it's in any other procedure, you can be a mature minor, with neurosurgery, and you don't, have to go through the court system. But in certain states, enshrined in legislation allows for guilty confidence, and those states are South Australia and Queensland now, with the recent Supreme Court hearing. But in Victoria, it doesn't stand. And the re-imaging case, that even if a young person is guilty competent, if one of the parents does not agree, then it has to go through family court. And this is why those young people, they make a choice. Some of them go, I'll just wait until I'm 18. Other families, we join them up with Justice Connect, who are pro bono lawyers, but you might not want to, they're the families that you might want to give to us, because it is a bit more tricky. We're the ones, as tertiary, we're happy to deal with complexity. And it's really hard, because I've had young people where the other parent is a perpetrator of family violence and he's incarcerated. And, just the mention of them, you can see them dysregulate in the room. And I have to say, you don't need to contact them. I can contact them, and they won't be released during this time, so does that feel okay to you?
That's really good to know, because I work in child protection. I'm a nurse and I coordinate the healthcare. And so we've had some young people that I have put referrals into your service. But it's, it's always this thing about, there is a parent that's incarcerated, or there is a missing, other parent or whatever. And yet this young person is really adamant about what they want. And so I'm just wondering, with the court process, how long could that take? How long's a piece of string, I suppose?
Yeah, it's months. And so if they're pubertal, some of them decide to wait. If they're ward of the state, it's a lot easier. Child protection can sign the consent for us. Yeah.
And that, that's a real dilemma for them too. They kind of really struggle in that space, yeah. But as I've said, look, it's, if we're referring to your service, and then that's where we kind of go with it, and we leave it to the professionals to have that discussion with the child and young person. Thank you.
And just to show how discriminatory it is, and because no other young person needs to go through this, you can be 12 and go and ask for an oral contraceptive pill, and GP doesn't need to tell the parent. All the cases have been passed through family court. So there's not been any time where the court has made a decision against what's been proposed by the medical staff. And yet we still need to go through it when there is a dissenting parent. Sahar, you're on mute.
Sorry, I was saying thank you. I think you were going to talk about some preparations that we could use in patients who, young people who have already reached puberty, or are there any resources?
Oh, so on our website, there is the standards of care has guidance around monitoring and starting. If you call the phone line and speak to our resident, we also have a set of consent forms where we've taken off all our logos so that you can use as your own, if you like, as well. But we can talk, we can talk you through that if you feel confident, and if you've got, you know, a mental health clinician involved as well in the care. So it's comprehensive, because it's not just you start the hormones, you've got to assess afterwards, what's the mood like? What's the irritability? That's why you also need a mental health clinician there. And how, because you don't just set and forget, you sort of have to go back and go, is this the right decision for you? Because the changes don't come straight away. And if they are wavering, there's a chance for them to go, well, actually, 3 months I stop. Or we have young people who decide that they have some level of masculinization. They might have a deepened voice and some increased hair, but they don't want the full facial hair. They don't want to keep having the treatment, and they go off it.
Thanks. And going back to your conversation where were you mentioning about the blood test that I think we didn't really complete that part. So are there, before referring, are there any specific set of blood tests, like, you know, the LH, FSH, or any preliminary blood test that we need to do as a part of referral process when we are?
No, you don't, because you can, but you don't. It's mainly if you get an idea of what pubertal staging they are. And it's really...
It's more like clinical assessment.
Yeah, clinically, you know, are they pre or post menarche? Has their voice dropped? Because also young people don't like having needles. Our staff here are really good at taking blood, but other services, you know, other providers might not be. And we don't want to subject kids to more than what they need.
Thanks. As like, I think any pediatrician or a GP who would like to, you know, just share your experience with, like, you know, how frequently you get to manage the situation, and how, you know, people who are not really familiar can, you know, learn from your experiences or support services. Anybody? Or I might just randomly ask somebody again. Vesna, your cats are so cute.
Oh, I've got 2 of them, and they're very needy because I came home from work late.
Dr. Martin.
I must have known you were going to pick me.
I was really controlling myself. I wanted to do that right from the start.
I have, at the moment, I've got a really tricky trans boy who I use the preferred pronouns and the mother does, but he's very reluctant to discuss it with the father. And mental health is a huge in and out of the children's with multiple self-harming attempts and suicide attempts. And there's nothing that I can do at the moment to convince them to let me talk to dad as well. So when dad brings the child to the appointment, I have to use the previous name and it's really tricky. And this young person has lots of other issues. So it's only one of the many issues that I deal with, and wasn't the first issue. I've known this person for years, so it wasn't the first issue that I saw them with. They didn't present with this problem. It's just evolved over me knowing them for several years and knowing the family. And I think that the father would probably be reasonable, but I don't really know. And it's just, it's really tricky. It's managing this family. And so I've referred them to a private psychologist who specialises, but even that's been tricky with them not wanting to know about, not wanting dad to know about at all. So it's just been a really incredibly tricky case. And I just wonder if there's any, they've also been referred to the children's with mum's consent, but not the dad not knowing. So it's been, so we're waiting on that. Post-pubertal and suppressing periods, so at least we're doing that. But it's really tricky seeing this person suffer.
Yeah. And so parents together, or are they separated?
No, together, and very you know, a couple of younger siblings, and it's unusual. You know, I've got lots of these kids, and it's one that really stands out for me at the moment, worries me constantly because of this child's mental health, really.
And so I've actually had young people like anticipate really extreme reactions from their parents. So young people say, oh, I was worried they would have kicked me out of home, and I was thinking about how I would find a job as a 14-year-old on the streets. So that will, what we call sort of internalized transphobia in a way. So I don't know, I want to know from Mum what she thinks.
Yeah, and I think, you know, Mum has already anyway, so it's very complex because I spoke to Mum on her own and said, what do you think? I've known the dad for years as well, and like there are cultural overlays as well and worries about grandparents and that sort of thing, but I think Mum has already maybe discussed it with Dad anyway, and the child doesn't know. It's very complicated. I feel like I'm well out of my depth, so hence having this referral to somebody who hopefully can, you know, they need some family therapy, I think, and but it's just in the meantime, this child's really suffering, and and I just don't feel like I'm doing enough really, but managing all the other issues. There's some social, they're one of those kids that changes when they go to school, and
that's a very difficult situation to be in.
And it is only one of the many difficulties. There's lots of learning difficulties and other things going on, ADHD and lots of other things going on too. So it's just it's tricky, and and it is, and they're post-pubertal, so I guess there's no urgency, and but you know, it's just managing the mental health in the meantime till they can socially transition or medically transition.
Sometimes it depends on what else they're on, whether they're on stimulants or are they already on an SSRI.
Yeah, so SSRIs have helped a bit as well, just with the anxiety. But I sometimes feel like I feel like this child hadn't had anxiety or depression before this presented, and I feel like if we could clear this up with the family and help them with this whole process, I don't think that maybe the anxiety and depression would still be there, but certainly some of the, really extreme mental health complications wouldn't have been, I don't think. Anyway, that was just
when you
idea is family therapy. Someone in the family.
When you
have you got any recommendations for family? Yeah, no, I've spoken to the GP. I've actually picked up the phone and spoken.
Are you a paediatrician? Are you?
I am a paediatrician. Yeah.
Yeah. Okay.
So I'm working collaboratively with the GP too, who I've actually spoken to on the phone and asked them to, to help me with the family as well, and to it's an evolving process, I think, and hopefully we'll just, if you hold their hand long enough. But in the meantime, this child's, really at risk too.
I think most of my kids are that complex. I just can't afford to see the private paediatricians or the private psychologists.
Yeah. Tricky.
Which makes it a lot trickier.
Yeah, very tricky for you to hold them, and it's really tricky.
It's really hard.
We've closed our books at the moment. I don't know.
I was just looking online and noticing
all the paediatricians have. I think mainly Melbourne. There's not many that are open, and it must be terrible for you guys having to. It's another conversation,
really
but I can't imagine how you can just hold everything. We're not even doing neurodevelopmental assessments on kids that need them at the moment. It's terrible. Trying to brainstorm and work out ways that we can.
But I'm interested that it doesn't sound like. So are you starting hormones? Do you start?
No,
hormones,
I've suppressed periods, but
Suppressed
this child is
periods
not
with
even. This child's not.
Or,
and we talked about the pill with the dad as well, because he wanted to know all about it, and we talked about it being in terms of regulating. I have many adolescents who benefit from the pill just because of fluctuating anxiety and
totally.
So it was that was a pretty easy thing to do, but in terms of other things, binders and
okay.
And sometimes there's some young people, they're so fixated on it, they can't shift. I had a young person who, until the laws changed and said that you needed consent from both parents, they didn't let me speak to their dad. And finally, when the laws changed and they had to, they did, and Dad was okay.
I really think this dad would be okay too. I can just keep chipping away with this person saying, I really think I could talk to your dad, because I know him from previously, and I know the other two kids in the family, and I really feel like I know this family as well.
But I think then Mum should be an advocate in a way.
Yeah, you're right. Yeah.
So what's happening there if Mum's not being an advocate?
Yeah, no, it's tricky. It's very cultural in their case as well. Very.
Okay. Yeah. Yeah, that's added.
I'm sure you would have. I'm sure you would have done that, but did you, like, what was the barrier for the mom, like when you had a chat with her, what was the barrier for her to bring it up? Like, is it like she's respecting the child's privacy, or is there any barrier that she can't really, advocate for the child?
I think she's a mum who's got 3 pretty challenging kids and 2 there's only one child that's hands full, and so really juggling the demands, which is where I think the talking to the GP, who mum's quite close to, probably really helped her sort out her own mental health, because I think she has her own mental health issues as well. It's just a really complex family, but it's whoever's crying loudest at the time. But I really felt that after the last hospital presentation, we need to do something for this kid, because they're really at risk of suicide, really.
Can I say something?
Please.
I have a mom and a teenager, and it's holding them from not getting the point where, if you don't go back to being, the good boy, I'm gonna kill myself. And the child is also feeling very suicidal because of not being able to be the person that they want to be. I wonder, like, I just want to pick your brain and say what's the best, support, because they all very hold on to mom, especially. You are the only child, then therefore, I need you to be the man of the family. And for her, it's almost like her world is shattered now, because that man is no longer what she would hoped to have, and she feel that if you can't go back and be the you that I want you, I would rather die. So how would you in terms of navigate through that?
Yeah, I think and again, it's work with the parents around this, and it sounds like even when she says that, she's talking about what her needs are, and you're saying this is actually your need as a parent. Which need is more important to you, your need as a parent, or the needs of your child in this?
Yeah, I've done that too.
Yeah, and what do you stand to lose? But also allow that time. Who are they worried about being judged by? Is it that there's the grandparents, and sometimes young people transition without grandparents knowing, actually.
That's right. They've been keeping it a secret. And I know that the shame, the fear that the mother is experiencing, but time is very important at this point, because it's impacting on the young person. And
And sometimes you do have that conversation. You can have your boy, but he's not going to be happy. He's not going to be able to achieve what he needs academically, educationally, socially, and he's at risk of mental health concerns. And particularly if you do think that suicidality is escalating in the young person. Or you can let your child try something else and see whether that makes a difference. But I've had parents where they're adamant they won't, and the young person does it eventually when they leave home, and sometimes they move states to do it. And what's really sad about it is that parent has now lost their child in a way.
Right.
Yeah, but that sounds like there are those cultural elements at play, and I'm not aware of multicultural support. It's at this stage for parents, there's general support, and even that, this is an emerging field. And I will tell you now, most of our presentations are of English-speaking backgrounds. We don't have. We know that there's gender diversity within multicultural communities, but we're not seeing it because the parents are not coming along and referring to us.
That's right.
Yeah, and it is that intense sense of shame.
So this family that I see are Greek Orthodox and quite religious, and daughters of these persons at a single-sex school. Very, very difficult, and didn't present to me for this problem. So this has come about as a child that I already saw. So I doubt that they even would have presented with this, or there even would have been a discussion. I think you're really right. I think we're not capturing a whole lot of, maybe there needs to be a lot more public work in organisations, you know, and different cultures talking about this as being, you know, something that happens across all cultures.
And yeah, I had a family like that, and actually the mum was living with grandma at the time, and eventually the young person didn't access hormones until they're 18 because mum said, I will find this over my dead body type thing. But she sort of did the if you don't, you know, don't say, don't hear, whatever that idiom is now. I've just lost it. And the young person did it at 18, lived with mum. Mum just access, so it's never happened. Doesn't use their preferred name or pronouns, but the young person can come to grips with, okay, this is all my mother can manage. They're talking to me, they don't use, but I'll just accept that. And so this is a real issue between a collectivist and an individualistic culture. How much do I have to lose myself so that you can still accept me? And that's a really hard choice. Who do you choose? You know, the family or the self? And we can't make those decisions and project onto it our own values and ideas around family.
It's funny, isn't it, though, because I really do appeal to them as parents, and I very rarely see a parent who doesn't have their child's best interest at heart and want their child to be happy above all else. So I talk a lot about that. You know, you've got a child, this isn't ideally what you would have anticipated, but you've got a child, you know, and again, with this young person, you know, they're at risk of losing their life. But it's, you know, I think I talk to them a lot about loving their child and wanting their happiness above all else, with lots of things, with, you know, decreasing academic expectations, kids with learning difficulties and lots of other things. But you rarely, I guess I'm privileged as well, but I rarely see people who bring their child to a private paediatrician who don't have their child's best interest at heart. So, yeah.
And we have to think about other settings where there are, you know, mercy killings of children for other reasons, for minor indiscretions, and where the society is. I'm thinking of Iran at the moment because of the news and what's happening, and where the people and the culture and the longevity of the culture is more important than the individual.
But it was interesting in Iran in the 70s, weren't they leading the way with gender?
So the story behind this is Iran has, you know, really good trans affirming surgery, and the reason why that is homosexuality is illegal. So people who are not trans have trans affirming surgery so that they can be with their partner of choice.
That's very sad.
It is very sad.
I lived in Myanmar, Burma, for 7 years. And one of the things I found really interesting there, and I have no idea whether this applies to any other cultures or not, but the way the language works is that your gender is not assigned to you, you assign your own gender. So the word for you, the word for he or she is the same word, no matter what gender you are or wherever on the spectrum you are. And when you say I, that's when you define your gender. And if you don't want to define your gender, you can just use your name when you talk about yourself, or you can use the word whatever you want, daughter, aunt, or, you know, whatever. But yeah, if you don't want to identify at all, you can just use your name. And even though it was a very kind of male, female, gender strong country, there was also this really broad spectrum of gender identity that seemed very acceptable. And there was kind of places and roles and norms that were very just obvious, you know, to anybody just walking down the street. And it's just, I've just always wanted to have this conversation, because culturally, sometimes I wonder how much this is an issue in when you use a Western language, because Western languages define gender. It's really, really important part of Western language. And
It's even worse if you're learning French or Italian.
Yeah, exactly. Like, yeah, English is bad enough, but French, yeah, exactly. Those languages everything's gendered.
The French introduced a neutral gender last year, and there was an uproar when the dictionary put that in as a possibility. But there's been gender diversity across time, across cultures.
Yes, exactly.
It's not something that is now created through the internet, through social contagion. And in other, so in Samoan culture, there's the Whawhawhine, who are effectively trans females. They're in First Nations cultures, they're referred to as brother boys and sister girls. So, yeah, and I think if we think, look beyond where we're living at the moment. But there's this moral panic as though there is something wrong when it's been there for ages. And it's just
I don't know, but sometimes I worry that maybe because we're in a gendered society, we don't have the space for people. I think it's improving again.
Yeah.
It's kind of bad and it's improving, but to be exploring different genders without making medical decisions.
And I am really, really optimistic about the future generation, because they might not ask for medical affirmation. Like my kids are in their, I've got 2 teenagers, but they refer to all their friends or people they don't know. They just use they, their pronouns without assuming what gender they are. And that's just the way it is. And it's not anything pathological. It's just like, okay, that's how it rolls now. And that's not saying you need to change anything, but allows for the possibility of what people can be.
Yeah, I agree.
I'm sorry, I'll have to cut you guys off. We're running over time. Thank you so much, everyone. This is the final of the series. Thank you so much for joining and coming back every month, and your valuable input and suggestions. Thank you so much, Dr. Prakash. Thank you so much, Shram. It was an amazing session today, and I learned personally, I'm sure everybody would agree so much from the discussion. So I guess it's time to say goodbye. Please, we'll send out the survey. So please give your suggestions and feedback. And if we all come back together next year, I hope to see you again. Thank you so much.
Bye.
Thanks so much, Pam.
Oh, and check out Dream Life with Georgie Stone on Netflix.
All right, will do. I actually have some free time. I might go and do it now.
Okay.
Thank you. Bye, Dr. Martin. Sorry I bothered you so much.